acquired brain injuries incorporates traumatic brain injuries. An acquired brain injury, or ABI, can result from traumatic injuries such as an accident at work, or a road traffic accident, sports injuries, or assaults. It might also include damage to the brain tissue following a stroke, or it could include a viral infection or a lack of oxygen to the brain. As the name suggests, an ABI is literally acquired during the individual's lifetime. It is an injury to the brain that has occurred after birth and is not hereditary, congenital, or degenerative. The injury commonly results in a change in neuronal activity which affects the physical integrity, the metabolic activity, or the functional ability of the cell. The term does not refer to brain injuries induced at birth. There are many definitions of what a traumatic brain injury is, and one such definition is the following. Traumatic brain injury is an alteration in brain function or other evidence of brain pathology caused by an external force. Traumatic brain injuries are injuries that lawyers are involved with. An acquired brain injury, which as we have highlighted includes a traumatic brain injury, might result in mild, moderate, or severe impairments. When reference is made to injury caused by trauma due to external physical force, the term traumatic brain injury is used. One may have a closed head injury or an open head injury. An open head injury is one that occurs where the skull has been penetrated and the brain has been exposed. A closed head injury often occurs when the skull is intact but the brain has been impacted. A closed head injury often results in more diffuse damage than an open head injury, but open head injuries are more vulnerable to secondary complications such as infection. It is crucial to remember that every brain injury is unique, as is the impact to the individual and indeed to the individual's family. The consequences of a brain injury can be divided into three categories. There can be physical consequences to include tiredness, headaches, movement, coordination and balance such as dyspraxia, speech and swallowing such as dysarthria or dysphagia, seizure, incontinence, just to name some. Cognitive consequences, on the other hand, might involve memory difficulties, attention difficulties, concentration difficulties, planning challenges, perceptual difficulties, and language difficulties. That leaves the third set of consequences, which are emotional and behavioural, and could include such things as agitation, personality change, anger and irritability, impulsiveness and disinhibition, including sexual disinhibition, motivation, depression, loss of control, selfishness, as well as lack of awareness and denial. The brain is made up of different lobes. There is the frontal lobe, which deals with attention, decision making, emotional, social, sexual control, expressive language, verbal expression, judgment, spontaneity, problem solving, motivation, motor integration, voluntary movement, and sequencing. There is the temporal lobe, which deals with behaviour, face recognition, short-term memory, receptive language, language comprehension, musical awareness, selective attention, object categorization, and locating objects. There is the parietal lobe, academic skills, awareness of body parts, eye-hand coordination, tactile perception, spatial orientation, object naming, right, left organisation, and indeed visual attention. The occipital lobe, which is the perception and recognition of printed words, visual perception and visual processing. Then there is the cerebellum, which is balancing and equilibrium, eye movement and coordination of voluntary movement, gross and fine motor coordination and postural control. Finally, there is the brainstem, arousal and sleep regulation, balance and movement, autonomic nervous system, which includes heart rate and breathing, the level of alertness, swallowing food and fluid. It is often the case that one lobe is injured, or I should say more than one lobe is injured, giving rise to an overlap of difficulties. In a brain injury case, the following specialists might be involved: a neurosurgeon, a neurologist, a psychologist, a neuropsychologist, a psychiatrist and a neuropsychiatrist, a rehabilitation consultant and a neurophysiotherapist. Indeed, any consultant that might be required to be consulted in respect of any of the individual challenges that we have alluded to above. The Glasgow Coma scale, which was first published in 1974, is simply a method to assess how significant a head injury is in any human post the age of 5 years old. It is used to objectively describe the extent of impaired consciousness in all types of medical and trauma patients. It divides into 3 parameters. There is the best eye response, which is E, the best verbal response, which is V, and the best motor response, which is M. The best eye response might be 1, and the worst is 4. 1 standing for no eye opening, 4 standing for eyes opening spontaneously. When we look at the verbal response, 1 would suggest no verbal response, 4 or 5 I should say would be orientated verbal response. When we look at the best motor response, 1 would suggest no motor response and 6 would suggest that the individual obeys commands. As you can see, a low score on the glaucoma scale would be very worrying, whereas a high score would be very reassuring. Lawyers will look at this assessment when considering a brain injury case and the impact that that brain injury might have on the individual. The lawyer will also be concerned to know what the family's views are and what the individual was like pre-injury and post-injury. If there are any matters arising from this video, or indeed that you wish to discuss pertaining to brain injuries, please contact me, Rafe McMahon, or my partner Jessica Goldrick on 01 677 0044. And many thanks for watching.